Okay, hopefully we are live and welcome to CTisus and hopefully this will fill in my entire screen. It's December 19th. This is the last official quiz of the year. So let's get started. I have a bunch of, great cases, probably a dozen of them, so let's get going. Patient with right lower quadrant pain and GI bleed. You can see in the first image a lot of ascites. Pancreas is prominent. Liver shows textural changes. And then there's a mass involving what appears to be the terminal ileum. It's bulky. You see it better on the coronal view. It's really the terminal ileum. You can think about Crohn's disease, but usually it's longer segments and it's not distended like that. It tends to be narrowing and an infiltrative process. Of course, you can have adenocarcinoma in Crohn's disease, and then it looks bulky, but here it looks like something that's thickening the wall of the bowel, but also dilating the wall of the bowel, and this is very nicely shown on these images. And so my thought would be tumor. Could it be an adenocarcinoma? That's a possibility, but you might see nodes, and it's also not obstructing. So the thing you think about, bulky lesion, terminal ileum, not obstructing, you got to think about lymphoma, and this was a B-cell lymphoma of the terminal ileum extending to cecum. GI bleed, you see thickening of the stomach. You also see thickening of the descending colon. Let's look at that a bit further. And you see it's really extensive thickening of the colon, particularly transverse colon, but it's really a pancolitis. And if you look at it a little bit closer, look at the ulcerations, particularly well seen in the transverse colon, dilated distal small bowel, a feces sign, and really impressive ulcerations in the transverse colon on the cinematic rendering. And this ends up being ulcerative colitis with ulcerations and crypt abscesses. Just a really nice example. This case, right lower quadrant pain, you see thickening with submucosal fat in the distal small bowel, but you also see the fibrofatty proliferation of mesentery. You can see on the coronal views the length of the terminal ileum thickening and narrowing. Think about that as opposed to the first case. And with the fibrofatty proliferation, this is most compatible with Crohn's disease, submucosal fat in the terminal ileum, narrowing, and prominent vasa recta. And this was Crohn's disease with high-grade dysplasia at time of surgery. Another patient, big spleen. Then you see textural changes in the spine, and you can see it's almost like a bone-in-bone appearance. You look at the images a bit further down, there's textural changes in all the bone, including the iliac bones and sacrum, and soft tissue mass in the presacral space. So now a big spleen, bony abnormalities, soft tissue in presacral space, and that appearance in the presacral space is very suggestive of one thing, and that's extramedullary hematopoiesis. So now you see a big spleen, bony changes, extramedullary hematopoiesis. You could think about something like myelofibrosis, but the appearance of the bone pushes you to a better diagnosis, which is going to be thalassemia. And we can see that very nicely here. The patient has beta thalassemia, commonly gives a big spleen. Sickle cell disease gives a normal or small spleen, and the bony changes are really good for thalassemia. Okay, next case, and I think you see the arrow on my computer, so things are going slow. But anyway, roulette appendicitis, I'll tell you, I'll get rid of the secrecy that the appendix was normal, but you see the spleen with multiple splenic lesions, and now we have an incidental finding, multiple splenic lesions, because the patient had right lower quadrant pain. You could think about lymphoma, you could think about metastasis, but there's no history for any of this. There's no adenopathy of note. And then you say to yourself, what else can give you multiple splenic lesions? You could think hemangiomas, but you got to think about sarcoidosis. Sarcoid can give you a normal or large spleen with single or multiple, but usually multiple lesions. And this was a great case of sarcoidosis of the spleen and incidental finding. Another case, another mass in the spleen, no adenopathy. What could this be? You can go from hemangioma, though doesn't enhance like hemangioma. The thing I would think about, the way it bulges, is hamartoma. Unusual things like literal cell tumors are often more cystic. It doesn't look like a sarcoma. Theoretically, it could be metastasis. Not a very specific appearance, but as an incidental finding with no other findings in the patient, this ended up being a hamartoma of the spleen. A very nice example. Fever, again, splenic lesions, spleens enlarged. Multiple liver lesions, which are in part vascular. You also see nodes in the peripancreatic region. The liver and spleen are enlarged with multiple lesions present. As you go to later phase imaging, the necrotic changes in the liver and particularly the splenic lesions are in fact better seen. So lymphoma is a thought, liver and spleen, though the liver lesions are a bit unusual. Metastasis like melanoma is a good thought. You got to be thinking malignancy. You're not thinking sarcoid because it's too mass-like, and the vessels and the changes in the liver are not sarcoid, which is hypovascular. This was Kaposi sarcoma. Kaposi's can involve the liver and involve the spleen and can be very vascular. Another patient, and I'm going to show you a few pelvic cases, groin pain. There's a mass in the patient's testes. I know we do ultrasound or MR typically, but the patient had pelvic pain and abdominal pain. This were the lower cuts on the CT. It's a solid mass with some vasculature in the periphery of the lesion. Here it is on the coronal view, solid mass. So you got to be thinking that we're talking about a testicular tumor, seminoma, germ cell tumor, but you also can have lymphoma, beautifully visualized on this patient's cinematic rendering. This was primary testicular lymphoma, a really nice case. Another patient. This patient, as the wheel of fortune spins, has a mass, but this is in the seminal vesicle. It's large and it's cystic. The right seminal vesicle looks fine. It's the left. It's above the prostate, as you can see in the coronal views. We think about prostatitis, but the seminal vesicle, which can be involved by tumor, also can be inflamed, and this was a seminal vesicle abscess. They're rare, but if the seminal vesicles are enlarged, it may be unilateral or it may be bilateral, you got to think about a seminal vesicle abscess, which is very nicely shown here. These patients can become very septic very quickly. Okay, another case. Complex pelvic mass, cystic, could be ovarian cancer. This is a female. When you look higher, you can see there's some clips by the pancreas, narrowing of the portal vein SMV confluence. I didn't tell you, but the patient had pancreatic cancer, and although in most patients you would think of ovarian cancer, once you see the pancreas, you got to think about a Krukenberg tumor, which in fact this was metastatic pancreas to ovary. You can see both the ovaries are involved, but again, that's pretty unusual. It's a Krukenberg tumor, but typically I would have thought about a primary ovarian tumor. Just a really nice example. Just a really, really good case. And again, Krukenbergs, we think about stomach, we think about bile duct, but you got to think about pancreas as well. Another patient with pelvic pain, complex cystic lesions in the pelvis, multiple septations. Yes, it could be ovarian cancer, but this was a younger patient with pain. When you're thinking pain, one of the great mimics is endometriosis. Endometriosis can be small or large, unilateral, bilateral, can look just like ovarian cancer, and this was endometriosis, one of the really great mimickers. Another patient is a mass midline. It's coming off the stomach. I would say this is a GIST tumor pushing on the pancreas, really well defined, but coming off the stomach. And I would say GIST every time. GISTs are typically exophytic, mildly vascular like this case is. This was resected. This was a schwannoma. Schwannomas of the stomach are rare, and very rare. And this is one of those schwannomas looking just like a gastric cyst tumor. So that's a dozen cases, I believe, and that's the end. So let me hope you got all the cases right, or you learned something. And let me also wish you, even though it's only the 19th of December, this is the last quiz for the month, a happy and healthy New Year and a happy and healthy holiday season. And with that, have a great day.